All right, so once we move beyond muscles, we now know that how muscles kind of contract and expand and shorten. We're on to kind of our levers, which is our hinge type mechanisms. So bones and muscles have to act together in order to create movement. So you not only need the muscle that generates the force of the movement, you need something that's able to move and to bend. So we need the bones, we need the joints, the muscles, and then what we call the load is the weight of the body part that is being moved. A lever essentially is a lever arm, a fulcrum, the force of movement, and the load, which is the amount that you want to move or push around. So levers can basically be found in a couple of different classes. We have our fulcrum, and it's easier to understand with the pictures. The fulcrum is between the load and the force. So that's your first class. So that is going to be something like your skull sitting on top of your neck. So the fulcrum, you're back and forth. You have the load, which is the muscles of your you have the muscles of your neck, which are moving, the force, excuse me. And then you have kind of the fulcrum, which is the lever, which is in between the fulcrum, where it is, where it can bend from. The second class, the load is actually in between the fulcrum and the force, so that's when you step up, something like this, where the force is actually being generated by your leg. The actual lever itself is your ankle, and the toes are where you're putting kind of the pressure. So that's a different kind of balance system lever. And the third one is where the force is in between the fulcrum and the load. So that's going to be your elbow, where you're actually lifting a heavy object. So those are your kind of three different types of lever movements. We tend to think of this more in terms of joint types and joint articulations rather than lever movements and where is the force and the load. There are three different types of joints in our body. We have synarthroses, amphiarthroses, and diarthroses. We tend to mostly focus on the diarthroses because those are our movable joints. An easy way to remember these is synarthroses is it stays there. It doesn't move. It's a non-movable joint. So these are the bones in your skull. When you're a child and they come together, they're not really intended to move, but it actually is a type of joint. The amphiarthroses is a slightly movable joint. It maybe has a little bit of limited mobility, but not a whole lot. And then our diarthroses are freely mobile joints, all the joints that we think of throughout our body. So bony joints, we can have several different types of articulations between these joints. A bony joint can be connecting two bones without anything in between. This would be a synarthrosis in the skull. A fibrous joint would again have no joint cavity but be connected by fibrous connective tissue, so a little tiny bit of flex to it, but not much. Similar with a cartilaginous joint, it's connected by cartilage. There's not really a whole lot of movement to it, but there's a little bit. Bones in your hands, certain of those are going to be cartilaginous joints. And then synovial joints are going to be joints that actually have a capsule that's filled with synovial type of fluid that provides a nice little cushiony sac. And those are the majority of our big moving joints. Types of movement. So we can have these different types of kind of joint articulations are going to allow us to move in different types of ways. So we can have a gliding movement, something that's gliding on top of each other, an angular movement where the angle is kind of created where we want to bend something, and we can have rotating type of movements. So each of these joints requires a different type of articulation in order to allow these movements. Obviously, if we took something like we wanted to take my finger and I wanted to rotate it, well, it's not that type of a joint. So it allows me to angulate, but it does not allow me to rotate. Whereas my elbow is going to allow me to rotate and to angulate, extend, flex and extend. So synovial joints have capsules that surround articulating surfaces, joint surfaces of two bones. So two bones come together, there's a little capsule that surrounds that surface, and inside this nice fluid, hopefully, that helps to cushion and prevent excessive friction, wear, and tear. It is part of your structural, it kind of contributes a little bit to structural stability, but mostly it's going to contribute to preventing excessive wear and tear. So we have our joint capsule. We have the cartilage, which is kind of this nice thing on the top of the bone surface. It kind of softens the bone surface. And then we have our synovial fluid that's in between. And all of these are very important. So we have this kind of like fluid-filled sac, but if that fluid-filled sac is sitting on top of something that has no cartilage, it in and of itself is going to get worn and rubbed more than it should, and is going to cause inflammation. Similarly, if you don't have enough synovial fluid in there, you might have the sac, but you don't have enough fluid to kind of create a little bit of a cushion, you're still going to get rubbing and wear and tear. So synovial joints are by and large are diarthroses. They are definitely there, and they can move freely surrounded by a joint capsule. And in this picture you can see that there is two bones coming together. There's a little cartilaginous cap on the end of each bone, and then there's this kind of little sac in between that separates the two bones from each other. When people have arthritis and we start taking x-ray images, what we'll see is the space between those two bones actually starts to disappear and to go away. So rather than having that nice kind of little distance there that's cushioned by your synovial joint, it's now sitting on top of each other and actually rubbing and grinding, which is what gives people the symptoms of arthritis that they have. So again, synovial joints, the bones should not touch. We have the articular cartilages that cap the surface, and then the fluid in between. There are 6 different types of synovial joints, and this is something you should know. Each one has very specific movement capabilities. We have plane joints, which have the least mobility. All the way down to ball and socket joints, which have the most mobility because they can really rotate in just about any direction. So our ball and socket most classically is our hip. A saddle joint has a certain amount where it can go forward and backwards like this, but it can also slide side to side like that. So think of being in the horse's saddle. You can kind of slide, and you can slide this way. That's your saddle joint. Your condyloid joints are kind of like a ball and socket, but without quite as much mobility. You can see that this picture over here, picture E, is showing a condyloid joint. And it's got a little bit of a ball and socket type rotation, et cetera, but it's not quite as big of a socket as your true ball and socket, and it doesn't allow you quite as big of a range of motion. So that's going to be present in the carpal bones of the hand. So you've got some of that mobility here, but you don't have quite as much as you would have with your hip. Pivot joints, let's see if we can find the pivot joint up here on your neck. So you can see that you have a certain amount of, a little bit of flexion between it, but you also have a tremendous rotation ability. So your pivot joints are going to give you your rotation. And then your hinge joint, like your elbow as well, where you're going to hinge this way, but you also do have a little bit of ability to rotate just a little bit. And we a lot of times think we have more ability to move our arm, but what we're actually looking at is our shoulder. So unless you stabilize the upper arm, you're getting upper shoulder mobility. All right, synovial movement, flexion and extension. Most of you will be familiar with this. This will be something you've seen back in nursing school, something you will see again in the health assessment classes. We talk about this a lot. Flexion is the upwards movement. Extension is the outwards movement. Hyperextension is when you go beyond what anatomically you should be able to. Some people, this can be a normal variation to have a little bit of hyperextension, but excessive hyperextension is obviously going to lead to injury of that joint and strain, destabilization of the ligaments around that joint, and etc. Abduction and adduction, this is our movements together and apart. If you think of add, means you bring something, you put it together. So that is towards the body, adduction. Abduction is the movement away from the center of the body. We can also have circumduction, so the ability to create a circle. We can do this with our hip, we can do it with our neck, we can do it with our shoulder. drawing a big circle on the board. So do you have normal circumduction? We also have rotation of the neck, lateral rotation, medial rotation. So when we say we're rotating laterally, if we think in terms of the shoulder, we're going to rotate laterally, which means outwards, versus medially, which means inwards. Medial, think of the middle. We're rotating towards the middle as opposed to laterally towards the outside. The elbow is a classic example of a hinge joint capable of angular type movement in one extension with a small amount of rotation that is possible from the elbow specifically. And the picture just lists the bones that are present in the elbow along with the specific muscles that are associated with it and the synovial type joint. All right, so then we have accessory structures. So that's kind of the basic structure of our synovial type joints. And then we have all these little accessory things that help to keep it functioning nicely. The meniscus is one of these. The meniscus is essentially a little kind of horseshoe or crescent-shaped bit of cartilage that is between the bones that acts as a little extra spongy layer of cushion. So we've all heard of things like meniscal tears. Essentially what's happening is you're tearing that little carpet pad, and now you don't have as much cushion between those two joints, and you're causing inflammation with movement rather than having a nice cushion underneath there. So that's what a meniscal tear is. We also have little fat pads that add extra cushioning that are going to be underneath our tendons and our ligaments. So we have ligaments that are going to be connecting bones together, and we have tendons that are connecting the muscles to the bones. Well, over time, as you're moving, those are shortening and extending. Well, they're actually rubbing against the bone. Well, rubbing against the bone is going to cause inflammation. So how do we prevent inflammation? We put little fatty pads under those areas. We're also going to talk about bursa, because bursa is another way that we pad and cushion against repetitive motion type injuries. So ligaments provide additional support, and what they're going to do is they're going to connect bones to bones. So again, tendons connect muscles to bones. Ligaments connect bones to bones. And there are many very important ligaments. A lot of the ones that we tend to be very aware of are the ligaments in our ankle, because those are the ones that when we sprain our ankle, we twist sideways and we're tearing or straining or excessively stretching the ligaments in the ankle, and we're destabilizing the bone-to-bone connection, even though the muscle to bone may still be intact. So ligaments provide a tremendous amount of stability for us and help to prevent us from constantly rolling or rotating those ankles into inappropriate positions. So again, while ligaments are strong, they are not invincible. You put too much strain on them, and they are going to stretch, or they're going to potentially tear. The degree of the tear is actually graded on a 1 through 3 basis. And so you can see in this picture we have normal as being kind of this ungraded, and then we have a grade 1 strain where we have stretched it, and there's kind of these small microscopic tears in it, but the overall ligament itself is intact. So the ankle joint is structurally intact. There's no sliding. There's no laxity of the joint when you do a drawer test on it. And I don't know if you're all familiar with what a drawer test is, but you're essentially taking a joint like a knee or an ankle, you're stabilizing, and you're grabbing the foot, and you're looking to see, does it draw forward? Does it slide underneath you? That's a drawer test. You should have a negative drawer test on a stable joint. When ligaments are torn, your ACL, your anterior cruciate ligament, your MCL, your medial collateral ligaments, or your LCL, which is your lateral collateral ligaments. Those are your common knee ones. When those are torn, you're actually going to get a sliding of the joint where the whole bottom part of the knee kind of slips forward. That's called a drawer test, a positive drawer test. So something like that might be a partial or a complete tear. That might be a grade 2 or a grade 3 type strain. So we would test that on both ankles and knees. Tendons, again, like we said, they're what's connecting the muscles to the bones. And while they're not specifically part of the joint itself, they are what provides the force for the movement at that joint. And muscle tendons are also cushioned by little kind of pads underneath that help to prevent repetitive motion injuries. These are bursa. So you've heard the term bursitis. Oh, I have a bursitis of my elbow. What we're really saying is that that nice little fluid-filled sac that has been acting as a cushion underneath your tendons has become acutely inflamed and has swollen up. This is typically due to excessive overuse. It can also be due to trauma if someone comes along and they bang their elbow really hard. This picture down there is a classic picture actually of an elbow bursitis, and it's exactly what it looks like. You'll see it sooner or later in clinical practice. It tends to be a little bit red, tends to be really big and spongy, and not really super painful. It's like it's a little bit uncomfortable, but they're not super painful. Sometimes it can be a little bit difficult to tell an elbow bursitis from a septic joint. And so you look at it and you're like, oh, how do you know that that's not the joint that's infected? Well, do they have pain with the movement of the joint, or is it really just a pain that's outside of the joint sitting in this little kind of bursa? This is a very classic joint. When you get a true septic joint, the whole joint itself is going to be swollen, but not with that kind of like bulgy little look of the bursa.